the INICET recall questions for the subject of oral pathology, oral medicine and DADH, which have appeared in the recent November INICET paper. So let us start with the first question from the subject of oral pathology. I hope I am clear, my audio and video both are clear. So let me start with the first question. Which of the following conditions has highest potential to become malignant? Here the question says that the chances of becoming malignant is highest. So if we see here, basically the options that are given here are proliferative verrucous leukoplakia, speckled leukoplakia, tobacco pouch keratosis, lichen planus. So here if you see, the first option is proliferative verrucous leukoplakia. If you see the option, we think that it is a type of leukoplakia. All of us know what is leukoplakia. It's nothing but a white patch. It is nothing but a white patch. This PVL is a specialized type of leukoplakia where the patient will have multiple white patches. If you see the question, description for this, that it is an aggressive lesion. All of us know it's an aggressive lesion. Aggressive means clinically it is aggressive. Clinically it is an aggressive lesion. 50% of the cases undergo malignant transformation. That means if 100 patients of PVL are there, 50 patients are going to develop malignancy. They are going to develop malignancy. Which malignancy will arise? OSCC, oral squamous cell carcinoma. OSCC. Okay. So look at that. What is the rate of percentage? Rate of percentage of malignant transformation is 50%. See, I am telling you one number. 50% is the average. If we take the range is 30% to 100%. Okay, so minimum 30% of the cases will undergo malignant transformation, maximum 100%. So average we have is 50%. So PVL is a very aggressive lesion with around 50% of the cases of malignant transformation. So usually carcinoma occurs more, oral cancer particularly occurs more in men. All of us know. The reason is simple, straightforward, because of the habits. In India, still men are the one who usually consume tobacco more. Okay, but this doesn't hold good in Western countries where this has shifted. Women also consume tobacco in the form of smoked tobacco. Okay, not smokeless tobacco. In India, what is practiced is smokeless tobacco. Okay, that is nothing, gutka tobacco, gutka and all other things. So where men usually consume more. Okay, however, PVL is a one where women are more frequently affected. Okay, and a patient will come to you, and if you see the oral cavity of the patient, there will be multiple white patches. As soon as you see such multiple white patches, what do you think? We think that it could be some malignancy or it could be some aggressive lesion. Okay, so and you ask the patient the history. What history you'll ask? We'll ask the history of tobacco consumption. The patient clearly gives negative history of tobacco and alcohol. This is a very important point. Negative history. If you ask the woman says that I don't consume alcohol, I don't eat tobacco in any form, but still the patient is having multiple white patches. So in such case, the most common etiology, so tobacco is not the etiology. So by this we can rule out that tobacco is not the prime etiological factor in PVL, proliferative verrucous leukoplakia. Then what is the etiology? The etiology is the virus, that is HPV16. human papilloma virus 16 is very common in case of these patients. So by this we come to the correct answer. Before going to the correct answer, here let me show you an image here. This image is very classical image of PVL. Okay, so this is an image which I have reported myself. This was a typical case where you can see the PVL on the buccal mucosa, PVL on the dorsal surface of the tongue. Okay, you can see that PVL is there in the floor of the mouth. So there are multiple sites. So patient has come with such white patches, multiple white patches in the oral cavity. Okay, so with this we can come to the correct answer that PVL is the pre-malignant lesion which has got the highest potential to become malignant. Okay, so this is the first question. So in this question, if you see, we have one option, that is tobacco pouch keratosis. This is not at all a malignant. This is not at all pre-malignant. That means it has got no chance of becoming malignancy. Why? Because it is not pre-malignant only. See, if anything is pre-malignant, then only it can become malignant. Tobacco pouch keratosis is not pre-malignant at all. Okay, so we can rule out that from this option. See, this is the way to study. How to study an MCQ is, while studying an MCQ, you have to go through the other options and you have to note down the learning point from each MCQ, each option. So from these options, we can note down that tobacco pouch keratosis is not pre-malignant. You ask the patient to stop placing the tobacco in the buccal vestibule, the lesion will disappear. The lesion will disappear. Okay, moving on to the second question. Men or male with an extra X chromosome most commonly seen with. So we know that basically, usually we know that this is simple genetics, that male have got XY and female have got XX chromosome. Okay, all of us know that basically males have got XY and females have XX chromosome. So there is one syndrome where the male has got XXY. What is that syndrome? That syndrome is nothing but Klinefelter syndrome. Klinefelter syndrome. So what question they are asking, they have asked here is that what is the oral manifestation that you see in Klinefelter syndrome patient? The oral manifestation that you see in Klinefelter syndrome patient is bull tooth. Bull tooth. Okay, so what is bull tooth? Bull tooth is the other name for Taurodontism. Taurodontism. The tooth, the crown of the tooth appears to be very large. That is why it's called as bull tooth. So Klinefelter syndrome patient will have Taurodontism. Okay, so instead of asking directly, what is the oral manifestation or the dental feature that you see in Klinefelter syndrome, they have asked in that way, that male with an extra X chromosome. Okay, so I'll show you an image of the Taurodontism. All of us know basics about Taurodontism, that it is basically a dental anomaly with enlarged pulp chamber. Okay, all of us know that, and it has been frequently seen in Klinefelter syndrome patients. Klinefelter syndrome patients. Okay. This is an IOP of Taurodontism patient. Look at this. This is a typical tooth which is affected. Look at the tooth. How does it look like? It looks like a bull. Why does it look like a bull? If you see here, the apical, this furcation, this is called as furcation area. The furcation area has shifted downwards. So it appears as if the crown is very large. This is first point, very important point. Note this point. Taurodontism is not a clinical feature. It is a radiographic feature. Taurodontism can be diagnosed only based on radiographic feature. RF is radiographic feature. Clinically, you can't diagnose Taurodontism. Okay, so you have to look at the radiograph. The radiograph looks like a bull-like tooth, large pulp chamber. Okay, that is what is Taurodontism. Okay, Riga-Fede disease is associated with. Okay, this is again a simple, straightforward question. All the MCQs, let me clarify one thing. All the MCQs have been discussed. Okay, there is in our this one during our session classes. Okay, so Riga-Fede disease is associated with vascular lesion, natal teeth, missing tooth, retained primary tooth. Okay, what is Riga-Fede disease? I'll show. Let me show you an image of first that. This is a Riga-Fede disease. This is a Riga-Fede disease. So this is a typical infant. Look at the infant. On the ventral surface of the tongue, you can see an ulcer. Okay, ulcer is seen. Where is ulcer seen? Ulcer is seen on ventral surface of the tongue. Why the ulcer is seen? Look at the tooth here. Look at the tooth here. We are able to see the teeth here. What are these teeth? These teeth are nothing but natal teeth. What do you mean by natal teeth? The teeth or the tooth that is seen at birth. Normally, when an infant will get tooth, 6 months, right? So as soon as after the birth, if you see teeth in the oral cavity, you call it as natal teeth. What this natal teeth will do? It will cause damage to the tongue. It is very sharp. It is going to cause damage to the tongue. Okay, as it is going to cause damage to the tongue, the child or the infant will develop an ulcer on the ventral surface of the tongue, which is known as Riga-Fede disease. Okay, so Riga-Fede disease is a traumatic lesion. What is the reason for trauma? Natal teeth. Where the ulcer is seen? Ventral surface of the tongue. Okay, all these are classical single liner MCQs. All these are classical single liner MCQs which we are supposed to remember. So by this we can come to know that this is a natal tooth. Another image of natal tooth where you can see. And remember, natal tooth is always seen in the lower anterior region only, mandibular anterior region. So Riga-Fede disease is associated with natal teeth. The description says that Riga-Fede disease is a reactive soft tissue disorder in neonates and infants characterized by ulceration of the ventral surface of the tongue. Remember, this is very important, ventral surface of the tongue. Often caused by continuous injury from natal and neonatal tooth. What is neonatal tooth? If a child develops, the child will have a tooth within 30 days after birth. That is called as neonatal tooth. Natal is at birth. At birth. If a child will have a tooth at birth, it's called as natal teeth. If a child will develop the tooth within 30 days, it's called as neonatal. So a natal teeth or a neonatal teeth can lead to Riga-Fede disease. Okay, let me go and discuss with the next question here. Consider the following: odontogenic keratosis, calcified falx cerebri, short metacarpals, enlarged head circumference. If you see all the four, which of the following combination is seen in Nevoid basal cell carcinoma syndrome? So this is one particular syndrome which is also known as Gorlin syndrome. Gorlin syndrome. So what do you see in this syndrome? We see basically multiple odontogenic keratosis. We see basically, what do we see? We see multiple odontogenic keratosis. Along with that, we also see calcified falx cerebri. So 1 and 2 are correct. We don't see short metacarpals. We don't see enlarged head circumference. Okay, so 1 and 2. So what is the correct answer? Obviously here the correct answer should be A. So multiple odontogenic keratosis are seen and falx cerebri is calcified. Okay, let me show you an image of this. This is an OPG where we can see. So what have we discussed? In Nevoid basal cell carcinoma, we see multiple OKCs. So let me show. This is the OPG. You can see here, there is one OKC here. There is one OKC here. There is one more OKC here. Okay, there is an OKC here. You can see there are so many odontogenic keratosis in this patient. So this is a characteristic OPG in a Nevoid basal cell carcinoma syndrome. One more thing I have told you, that in Nevoid basal cell carcinoma syndrome, the patient will also have calcification of the Falx cerebri. What is falx cerebri? If you see in the midline brain, that is a soft tissue, which is soft tissue, right? It should not be visible on a X-ray. So if you see visible falx cerebri, because it is calcified, because on X-ray you are able to see that falx cerebri calcified. So this is a characteristic image of again the Gorlin-Gotts syndrome patient or Nevoid basal cell carcinoma syndrome patient. Okay, so remember two important things: multiple OKCs and calcification of the falx cerebri. Nikolsky sign is absent in. Now, what is Nikolsky sign? All of us know that Nikolsky sign is basically a skin sign where we basically apply tangential pressure on the lesion, around the lesion. Okay, so this is characteristically seen in case of pemphigus. It is typically seen in case of pemphigus and even in case of pemphigoid. Which pemphigoid? Mucous membrane pemphigoid. Okay, it is absent in bullous pemphigoid. It is absent in bullous pemphigoid. So let us discuss few things about the. This is all single liner, straightforward single liner question. Nikolsky sign is pathognomonic for pemphigus, toxic epidermal necrolysis, and staphylococcal scalded syndrome. It is also seen in mucous membrane pemphigoid. Remember, but it is absent in bullous pemphigoid. Remember, two types of pemphigoids are there. One is mucous membrane pemphigoid, another is bullous pemphigoid. Bullous pemphigoid will not show Nikolsky sign. That is a characteristic point you have to remember. Okay, this is a very single liner question, commonly frequently asked in case of NEET papers. All of the following lesions will show Nikolsky sign positivity except, and most common option that is given is bullous pemphigoid only, because bullous pemphigoid will not show Nikolsky sign positivity. This is an image just to demonstrate what is Nikolsky sign. Usually they use a thumb, okay, and they will apply the pressure. Suppose you can see here, this is a lesion. The person is applying the pressure around the lesion, okay, perilesional skin. You apply the pressure, a new lesion will develop there, or the skin will peel off. The skin will peel off. That is called as Nikolsky sign positive. Which of the following tumors develop from odontogenic mesenchyme? Okay, so we know that odontogenic tumors will arise from ectoderm, mesenchyme, and combination of these two. There are three origins for odontogenic tumors. One is purely from the ectoderm. One is from the mesoderm. One is from combination of both above. So what is the question that is asked? The question is asked about this, which is exclusively from the mesoderm or mesenchyme. So there are only two here, that is the odontogenic myxoma and cementoblastoma. So 1 and 3 are the two which arises from basically the exclusive mesenchymal component. There is no ectodermal component here. So the correct answer should be 1 and 3. So here we will go with this option. Option D. Because option D is 1 and 3. Odontoameloblastoma and the AOT. AOT is purely ectodermal. AOT is purely ectodermal. Odontoameloblastoma is combination. That means it arises from both the ectoderm as well as mesoderm. True microdontia of maxillary lateral incisor is called. So if you see true microdontia, that means what is microdontia? Small tooth. Usually microdontia frequently affects the lateral incisor, maxillary lateral incisor. So do you call it as peg-shaped laterals? This is a single liner MCQ. There's nothing to discuss much in this. So it's a peg-shaped lateral. They call it as peg-shaped lateral, where you see a small maxillary lateral incisor. Identify the following abnormality. If you see carefully, look at this tooth, look at this tooth. So it is appearing as if one tooth is trying to split into two. Okay, so there is an attempt to divide. So this attempt to divide is a characteristic feature of gemination. We know that there are two things. One is gemination, one is fusion. What is gemination? If a single tooth but it tries to divide into two, you call it as gemination. What is fusion? If two tooth buds try to fuse together and form one tooth bud, that is called as one tooth, that is called as fusion. Division is gemination. Fusion is, as the literal meaning, fusion means two tooth bud will fuse. So this is where we can see typically there is the gemination. Identify the diagnosis in a male patient with a tongue lesion enlarging progressively. Look at this. So this is a typical tongue lesion where we can see multiple small vesicles on the tongue. Okay, we can see all these small vesicles on the tongue, and these small vesicles, they appear like frog egg. Okay, so this is a characteristic lesion that you see in case of lymphangioma. So in a lymphangioma, you will see such a typical characteristic image where on the tongue there will be multiple small vesicles which are called as frog egg appearance, and this leads to what? Large tongue or macroglossia. So one of the common cause, or we can say in the list of causes for for macroglossia, lymphangioma is also one of the important that you should remember. You should remember this name, frog egg appearance. Frog egg appearance of the tongue is typically seen in case of lymphangioma. Okay, moving on to the next question. Bilateral expansile mandibular lesion is characterized by. So look at the question. What they're saying, bilateral. That means mandible. The lesion is affecting mandible. Bilateral, both sides, right side, left side. And the lesion is expansile. So it is expanding. Okay. Whenever we see such typical description, bilateral expansile mandibular lesion, that too in a child, young patient, what should come to your mind? Cherubism. All of us know. When do we call cherubism? Cherub means swollen cheeks. Cherub patient. When we call it cherub patient, that means swollen cheeks. Why is that cheek swollen? Because the mandible has expanded. It is not unilateral lesion, it is bilateral lesion, expansile lesion, and typically it is multilocular lesion. So these words are characteristic. Bilateral, multilocular, expansile, mandibular lesion is characteristic feature of cherubism. And all of us know cherubism is now classified as a type of FD, fibrous dysplasia. Okay, there are basically three types of fibrous dysplasia: monostotic, polyostotic, craniofacial. Now the fourth one that has been added is cherubism. So cherubism is considered now a type of the fibrous dysplasia. Okay, moving on to the 11th question. What is the diagnosis peculiar to this radiograph? Look at this skull radiograph, lateral skull. We can see multiple punched out radiolucencies. Where do you see multiple punched out radiolucencies? Multiple punched out radiolucencies are characteristic feature of multiple myeloma. Okay, so this is a typical patient of multiple myeloma where we can see punched out lesions. Why they have given Paget's disease? In Paget's disease also you can see such lesion. You can also see such lesion in Paget's disease. Okay, where you describe it as cotton wool appearance. Cotton wool appearance. A 24-year-old woman presents to the clinic with the painful ulcers which rapidly progressed. Histopathology reveals ballooning degeneration of epithelial cells and Lipschutz bodies. What is the diagnosis? So first, what description they have given here? They have given a description of painful ulcers. Ulcers are painful. Then histologically ballooning degeneration is seen. Third point, Lipschutz bodies. So typically this is seen in case of herpes. So herpes is one viral infection where you see painful ulcers. Okay, here I want you to remember the list of painful and painless ulcers. Which are the oral ulcers which are painful, which are the ulcers which are painless. Painful ulcers, one of the important one is herpes, is a painful ulcer. Traumatic ulcer is a painful ulcer. TB ulcer, ulcer in the TB, that is tuberculosis in the oral ulcer, is painful. Okay, we have to remember these painful ulcers. Painless, even aphthous ulcers. Aphthous ulcers are also painful ulcers. Painless ulcers, one of the characteristic painless ulcers are malignant ulcers. Ulcers due to malignancy in the oral cavity are painless. Even syphilitic ulcers are painless. Syphilitic ulcers are also painless. Okay, so this list is again very important list where frequently question comes on this. Which are the painful ulcers, which are the painless oral ulcers. Okay, so all these highlights which I have given here, painful ulcers, ballooning degeneration, Lipschutz bodies, are characteristically seen in herpes. So what are Lipschutz bodies? These are nothing but new inclusion bodies, intranuclear inclusion bodies. Within the nucleus you see some extra body. That extra body is called as Lipschutz bodies. And what is ballooning degeneration? The cells become swollen. How a balloon is swollen, right? So epithelial cells in herpes are swollen. So they describe it as ballooning degeneration. Okay, so sometimes you can get a characteristic single liner question. Which is the viral infection which shows ballooning degeneration of epithelial cells? Answer is herpes. The term enameloma refers to. See, once you look at this term enameloma, enameloma means what? First thing that comes to your mind is oma, that it could be some tumor like lymphoma, sarcoma. It could be some tumor, right? Exactly, it is not a tumor. It is not a tumor. It is just a tiny globule of enamel that is seen on the root. So it is not a tumor. Please remember this. Enameloma is not a tumor. It is just an extra mass or globule of enamel. Okay, let me show that. So if you can see here carefully, this is a furcation area, and here this shiny pearl-like is nothing but enameloma. Is nothing but enameloma. So it is just an extra mass of enamel that is seen on the root, that to the furcation area. We go to the next question. Tooth-like structure on either side of the roots of permanent central incisors are seen in an IOPA. What does the structure depict? That means they have not given an IOPA here. This is even though it's an image-based question here. So there is an IOPA, that is an X-ray. Tooth is there, lateral incisor is there, central incisor is there. Just adjacent to that roots, we are able to see some tooth-like structures, multiple tooth-like structures. What do you call it as? I'll show you an image of that. For example, this is a tooth, right? These are all the teeth. This is a tooth, this is a tooth, this is a tooth here. I can see something extra here. These are small pieces, okay, hard tissues, which look like tooth only. They're hard tissues. What are they exactly? They are nothing but compound odontome. So odontome is an odontogenic tumor basically, which has got two types, compound, complex. When do you call it as odontome compound? When the odontome resembles like tooth, you call it as compound odontome. When do you call it as complex? It has got no resemblance to the tooth, you call it as complex odontome. So basically, if you look at the question, they want to ask you that whenever you see in a radiograph multiple small tooth-like structures, what it could be? It could be a compound odontome. It could be a compound odontome. Okay, let us move to the next question. Dentinogenesis imperfecta transmits as autosomal dominant trait and occurs due to mutation of which chromosome? Characteristical single liner MCQ, chromosome number 21. Okay, so dentinogenesis imperfecta usually occurs due to the gene called as DSPP gene mutation. So dentinogenesis imperfecta occurs due to the mutation of this gene DSPP. What is DSPP? Dentine silophosphoprotein. Dentine silophosphoprotein. Where is this gene located on? This gene is located on 4q21. I hope all of us know how to read a chromosome number. What is 4q21? It is seen on 4th band on Q is long arm. Q means long arm of chromosome number. What is the chromosome number? Chromosome number 21. So this particular gene is seen on 4th band on long arm of chromosome number 21. Q is long arm. What is P stands for? P stands for short arm. Okay. So if I write 4p21, what is 4p21? 4p21 means 4th band on short arm of chromosome number 21. But DSPP gene is seen on 4q21. That is 4th band on long arm of chromosome number 21. Instead of asking so much complicated, but they have simplified which chromosome number? That is 21. 21. They have not asked the band number also. They have not asked the arm also. Which arm of the chromosome? Long arm or short arm? But still, we should be aware of this. 4q21 is characteristic for dentinogenesis imperfecta. Let me show you an image of dentinogenesis imperfecta where you can see here characteristically the brownish discoloration of the teeth that can be seen here. Okay. Okay, let us move to the next question. Which of the following is not a predisposing factor for oral myiasis? All of this is a very characteristic question. A lot of questions come on oral myiasis. This time, I think this question has come. So we should be aware few things about oral myiasis. Basically, this is a infection that occurs due to larva. Okay, a larva of one fly that is called as a dipteran fly. Okay, so this myiasis, oral myiasis. In which patients you see this oral myiasis? Commonly, you see these patients in case of low socioeconomic status patients. Low socioeconomic status. Why? Because of poor hygiene. So oral myiasis is one of the main reason for oral myiasis is poor hygiene, poor sanitation, poor oral hygiene. Because of all these, usually you see oral myiasis. So what are the question that is asked? And this is also commonly seen in mental retardation patients who don't have, why in mental retardation? Because they don't have the ability to maintain the oral hygiene. Okay, so this oral myiasis can be seen. So which of the following is not a predisposing factor? Look at this, what they're saying, which is not a predisposing factor. Cerebral palsy, yes, because cerebral palsy patient will have mental retardation, so oral myiasis can be seen. Poor oral hygiene, yes, we have discussed. Improper sanitation, yes, we have discussed. Proclined incisor is not a predisposing factor. That means if an individual has proclined incisor, he might not develop oral myiasis. So oral myiasis, proclined incisors is not a predisposing factor for oral myiasis. Okay, so we should remember that oral myiasis is one very common larval infection which is very prevalent in India. Next is Brazil. India and Brazil are the two countries where you can see this commonly, but more is prevalence is there in India, and which is the oral cavity part where you see commonly this lesion is gingiva. So remember these two questions also, that in India you see frequently, and in gingiva is the most frequently affected area for oral myiasis. Okay, so I'll also discuss some few questions that have appeared from the subject of dental anatomy, oral histology. Okay, so these are the questions which I have discussed about oral pathology. Now dental anatomy we have, and oral histology we have three questions. At what time during intrauterine life does the palatal shelves begin to fuse? So intrauterine life means in the mother's womb. Okay, in the mother's womb, the palatal shelves have to fuse, right? The palate has to fuse. So typically, if you see, the palatal shelves usually begin to fuse by 9 weeks. By 9 weeks, that means during the second month of pregnancy, the palate will fuse. Start fusing, begins. When it completes, by 12 weeks, it completes. So now here the question, look at the question. Neither we have 9 week here. Neither we have 8 week, not but 10 week. The option that is given is 6, 8, 10 and 12. And what they have asked? They have not asked completion. They have asked beginning. So here the confusion usually the students will have between these two. Whether I should go with 8 or whether I should go with 10. Because mean is 9 weeks. Always go with the earlier 8 weeks. Okay, so you can go with the best option that I can say here will be the 8 weeks. So by 8 weeks, the palatal shelves will begin to fuse, and complete by 12 weeks. Okay. Next, which of the following is not a successor from the given OPG? See, what is a successor? Successor means it should have some predecessor. Usually we say a successor. This is a king who's a successor. That means he had one more king before. He has succeeded him, right? So if you look at this, which is not a successor from the given OPG, is that it is not having any predecessor. Typically is nothing but the 1/6, because 1/6 is nothing but your the permanent molar, where it will not have any case of the successor predecessor. Which of the following gives rise to calcified tissues of the teeth? Look at the question here. Which of the following gives rise to calcified tissues of the teeth? We know that calcified tissues of teeth means enamel, dentine, cementum, right? I'm sorry, enamel, dentine and cementum. So enamel purely arises from ectoderm, and dentine and cementum arises from mesenchyme or mesoderm. So if you see this, typically the ectoderm and mesoderm is the correct answer for this. So calcified tissues of this arises from basically the combination of ectoderm and mesoderm. Okay, I hope this is clear. So these are the questions which have appeared in the recent November INICET paper. All these questions have been discussed and they are straightforward. They are usually straightforward. This time the questions have been bit much more simpler. Otherwise, usually genetic aspects are more common in INICET. Okay, these questions are usually characteristically asked in NEET paper. Such questions are usually asked in NEET paper. Okay. Thank you very much for the patient listening, and any doubts you can ask me. Feel free to ask your doubts so that we can discuss anything that is there. Otherwise, you can go through this video, go through this session, and my sincere suggestion is the way you have to attempt an MCQ is going through the options. So the one of you are asking first question. Please repeat first question. PVL. Okay. There's a question here that which of the following pre-malignant conditions has the highest potential to become malignant? Okay. So this is basically a PVL. All of us know that PVL has got a very aggressive lesion where the malignant transformation rate ranges from 30 to 100. Okay, average is 50. And usually women are more frequently affected by PVL, and there is a negative history of tobacco and alcohol. There is one more question here about Nikolsky sign. There's a doubt about Nikolsky sign. So Nikolsky sign is basically there is a lesion. This is a sign that is seen in the skin where It is seen in all types of pemphigus. Remember, it is seen in all types of pemphigus. You see this Nikolsky sign positivity, and you see in one group of pemphigoid, that is cicatricial or benign mucous pemphigoid. You don't see Nikolsky sign in case of bullous pemphigoid. Bullous pemphigoid is one type of pemphigoid where you don't see the Nikolsky's sign. Okay, so this is a image of the Nikolsky's sign. I hope this is clear, and I hope this session would have helped you. We'll try to get such more sessions in future. Okay, thank you very much.